So as we look at biologics in 2015, we recognize that for certain forms of vasculitis, biologic agents have become a very valuable treatment option. And interest in biologics and vasculitis remains high for whether they may be able to interrupt our pathophysiologic mechanisms that are involved in disease, reduce disease relapses, decrease glucocorticoid requirements were a substantial goal in our diseases today, and provide a therapeutic alternative to our current approaches. Publications using biologics continue to grow in number, and while these increasingly do involve randomized trials, some do still consist of case reports and case series. And because of that, before we choose to use a biologic agent in clinical practice, we do have to broadly examine the benefits, the risks, and the goals of therapy for our patients. When we weigh the issues in deciding to use a biologic agent in a patient with vasculitis, the aspects that we do have to consider include the effectiveness of our current standards of care, what is the goal of using a biologic agent in a specific patient, and the strength of the safety and efficacy data in that setting. This includes not only for our randomized trials, but also open-label studies and retrospective reports with regards to the number of patients that are being studied, the outcome measures that are being used in those studies, the use of concomitant therapies, the length of follow-up, as well as the safety. Today, we're going to examine data not only in GPA as well as our large vessel vasculitides, but I also wanted to share with you some of the data regarding other diseases for which there has been increasingly emerging data, particularly some recent exciting studies that have just come out in recent months in cryoglobulonemic vasculitis, Behçet's disease, and EGPA Churg-Strauss. But let's begin first with granulomatosis with polyangiitis, or GPA, which is a disease characterized by small to medium vessel vasculitis in which we recognize the clinical and histologic characteristics. In 2015, we do have a broad armamentarium of therapeutic choices, which does include a biologic agent in terms of rituximab, both for induction and now increasingly maintenance of remission. So the questions become, how did we get to these approaches, and what role do biologic therapies play in the overall treatment approach in 2015? The story of biologic agents in GPA certainly were initially prompted by one of the characteristic findings in this disease, which is the presence of granulomatous inflammation. And as biologic therapies became increasingly available in rheumatology and in clinical practice, the role of granuloma formation, and particularly the role of CD4 positive Th1 cells in terms of the initiation and maintenance of granuloma formation, made an interesting case for whether TNF agents, which were becoming increasingly available, could beneficially influence GPA. This led to the important study of etanercept in one of the first randomized trials conducted in this disease, in which the role of etanercept to sustain remission was investigated. Unfortunately, as we learned from this trial, etanercept was no more effective than placebo in sustaining remission for over 6 months, supporting that etanercept did not provide a useful role in this disease. Whether other anti-TNF agents that may have a different mechanism could be more effective, as was seen in other inflammatory diseases, this was explored in other smaller scale studies where, again, a high rate of relapse and unfortunately a higher rate of serious infections was seen. And although it can be argued that a sufficiently powered study of these agents really hasn't been performed, current evidence does not support the use of anti-TNF therapies in GPA. However, our interest in exploring biologic therapies was in no way diminished, and in thinking about other potential mechanisms, inhibition of B-cell pathways and specifically the role of rituximab increasingly began to investigate it. Following exciting case reports and case series, randomized trials were conducted to explore the efficacy of this therapy. These were published in the New England Journal of Medicine, which included the RAVE trial. In this study, cyclophosphamide going to azathioprine was compared in a blinded fashion against rituximab given on a schedule of 375 milligrams per meter square per week every 4 weeks. The primary endpoint of this study was being in remission and off prednisone in 6 months. And in this trial, rituximab was found to be as effective as cyclophosphamide. And in a sub-analysis of those patients enrolled at the time of a relapse, rituximab appeared to potentially be more effective. Now, in looking at the rate of adverse events overall, rituximab had a similar rate of adverse events with cyclophosphamide, likely reflecting the effects of high-dose steroids as well as the effect of disease. But even at this point, there was a rate of relapse that was being seen, but there was a low rate of mortality in this study. Now, it is important to recognize that although these patients did have severe disease, therefore justifying the use of cyclophosphamide, there were important exclusions in that those who were the sickest of the sick, who had a creatinine of greater than 4, or who required mechanical ventilation, were not enrolled in this study. Nevertheless, this trial provided compelling evidence to support that for remission induction, rituximab is as effective as cyclophosphamide, and this study provided the basis for FDA approval of rituximab for GPA and MPA in April of 2011. Now, another important study that was published in the same New England Journal of Medicine was the RetuxVAS trial from the European Vasculitis Society. This study was designed slightly differently and provided further insights into the efficacy of this agent. This was designed as a superiority trial to determine whether rituximab was potentially more effective than cyclophosphamide. And another aspect of this study we can see is that all of these patients received 2 doses of IV cyclophosphamide prior to their randomization to receive rituximab or continue with cyclophosphamide. In this study, although rituximab again appeared to be as effective as cyclophosphamide, it was not found to be superior to cyclophosphamide and did not meet its primary endpoint. Once again, the rate of adverse events was comparable between the study arms, but there was a high rate of mortality of 18%, likely reflected by the median age of 68, and that 20% of these patients were on dialysis, both of which have been known to be outcomes measures associated with poor outcome for these patients. Nevertheless, this trial did provide compelling evidence that rituximab was effective but not superior to cyclophosphamide. So a question also often has arisen that as it is effective as cyclophosphamide for remission induction of severe disease, does this mean that it should be used to induce remission in everyone at this point in time? And I think the answer still remains no for right now, in that there's not strong data for all populations. If we look at the strength of evidence for use, I think, of course, the most compelling evidence we have is for those who have relapsing severe disease. But again, those who have the most fulminant disease with renal insufficiency of a severe nature or requiring mechanical ventilation were those who were excluded from the RAVE trial and where there is to date the weakest evidence for the use of rituximab. Another question that arises is what happens after rituximab, and this was explored in the longer-term data from the RAVE trial, looking at the relapse experience after a single course of rituximab. Although there appeared to be no difference in the rate of relapse between those treated with rituximab versus cyclophosphamide, nevertheless, a 30% relapse rate was seen within 1 year. This made us recognize that relapses do still occur after rituximab, such that a plan for remission maintenance needs to be considered in each patient. The options we have in this setting include close clinical observation and retreatment with rituximab for relapse should this occur, the use of a conventional maintenance agent as we would use after cyclophosphamide with methotrexate, azathioprine, or mycophenolate, or the use of scheduled repeat rituximab infusions. So what do we know about the use of rituximab for maintenance at this point in time? We had the first publication of results from the Maritson study conducted in France in the New England Journal of Medicine last year. This trial explored the use of rituximab for maintenance after IV cyclophosphamide induction, and this was compared to azathioprine given on a dose-reduced schedule, and where rituximab was given as 500 milligrams 2 weeks apart at days 0 and 14, and then every 6 months until month 18. We can see in this trial, there was a lower rate of rituximab relapses in the rituximab arm, which was statistically significant. But this study also raised important questions in terms of how did the dose reduction and ultimate discontinuation of azathioprine impact the relapse rate, whether there was sufficient time to assess the rate of rituximab relapse. And in clinical practice, as this is now a chronic disease, what do we do after 18 months in terms of continuing or not with rituximab treatment? So I think this does provide evidence that rituximab is an option for maintenance after cyclophosphamide, but questions do remain regarding long-term maintenance, for which we will get additional answers from ongoing studies that are being conducted internationally. Another agent that we have been exploring is the use of abatacept, or CTLA-4 Ig, and again, the rationale for the use and investigation of this agent was based upon whether interference with T-cell activation could influence GPA and benefit disease. This was explored in an open-label pilot study of 20 patients who had non-severe relapsing GPA, which is a population of unmet need, in which we saw 90% disease improvement, 80% remission, 70% reaching the common closing, and a high percentage who were able to come off and remain off glucocorticoids, and which we also saw a favorable safety signal. This has prompted the conduct of a randomized trial, which will be starting in 2015. And again, at the current time, the use of abatacept in clinical practice, there's really insufficient evidence to recommend using this on a broad scale. So in turning then to large vessel vasculitis with giant cell arteritis and Takayasu arteritis, we recognize that these are diseases that share many similar features, including large vessel involvement, the response and toxicity to prednisone, a high frequency of disease relapse, and granulomatous vasculitis. So the question becomes, what has the experience been with biologics and GCA and Takayasu's, and does the treatment response differ? The investigation of these biologics has been guided by our hypotheses about pathogenesis, in many ways similar to our other diseases. So when we think about what our current understanding has been with GCA and Takayasu, there has been long-standing evidence to support this as having been an antigen-driven disease. And this has been based upon the studies in the laboratory as well as the investigation of tissue production of pro-inflammatory cytokines. Once again, there was great interest about the role of anti-TNF agents in this disease based upon these mechanisms and encouraging pilot studies. This led to the conduct of a randomized trial in which infliximab was compared to placebo in patients who received standardized glucocorticoids, with the primary endpoint being the proportion of relapse-free subjects through week 22, with a secondary safety endpoint. What was found was that, unfortunately, infliximab was, again, no better than placebo, and also, quite concerningly, was that there was a higher rate of infections seen in these patients as compared to placebo, also likely contributing with the high-dose steroids. So this study, again, provided evidence that infliximab did not provide benefit to these patients in the treatment of giant cell arteritis. Now, there were certain investigators that did question whether this study was too small or whether the results were agent-specific, and there was a randomized trial of adalimumab in 70 patients, which also did not show efficacy, providing further evidence for the robustness of these original data, again, supporting against the use of anti-TNFs in GCA. Now, interestingly, the story has been slightly different in Takayasu arteritis, although, again, on this admittedly busy slide, one of the things we need to recognize that all of these represent retrospective case reports or case series. In looking at two of the larger series published from here at Cleveland Clinic and well at the Mayo Clinic, What we can see in these studies of 25 and 20 patients was that anti-TNF-based therapy did appear to have evidence for effectiveness, although relapses did still occur and adverse events were seen as well. This experience has suggested that the use of anti-TNF therapies in Takayasu arteritis has been encouraging, although further study through a randomized trial would really be needed in order to definitively prove efficacy. Now, another area that has been of great interest for a considerable period of time has been the role of IL-6 in GCA and Takayasu. And this has been not only as far as with its utility as an acute phase reactant, where the results were found to be variable dating back to the early 1990s, as well as, again, studies of expression and production in giant cell arteritis tissues. This question led to the question as to whether this could provide a novel means for treatment of GCA and Takayasu. Tocilizumab has been of great interest in these diseases, and again, we can see on this slide the increasing publication of studies since 2008 investigating the use of this agent. Overall, in these series, a beneficial response has been observed, but there's been questions about what the reduction of acute phase reactants means in conjunction with this agent, complicating our outcome measures in these difficult diseases. And additionally, there have been two reports, one in GCA and one in Takayasu, where ongoing vascular inflammation, despite treatment, has been observed. The efficacy of anti-IL-6 in GCA and Takayasu is currently unknown, and a randomized trial is being conducted in giant cell arteritis, which the enrollment has recently been completed and which we await the results with great interest. Abatacept has also been explored in these diseases, again, based upon the rationale about whether inhibition of T-cell activation could benefit these diseases. This has been the focus of randomized trials in GCA and Takayasu, which have completed enrollment and are which awaiting ongoing analysis. But again, at the current time, there's really been no experience to date with this agent to support its use in clinical practice. So what about B-cell depletion in GCA and Takayasu's? There's again been efficacy in small vessel vasculitides. What about the large vessel? And admittedly, for many years, the interest in exploring B-cell-based therapies was very limited due to the paucity of evidence supporting their participation in pathogenesis. However, there have been studies increasingly looking at this. In Takayasu, there are observed disturbances of B-cell homeostasis, as well as small case reports where B-cell-based therapies have been used. There has also been data supporting potential benefit in IgG4-related aortitis, which raises a question about whether there could be confounders in some of the Takayasu data. So it is unclear at the current time whether rituximab warrants further study in large vessel vasculitis as far as GCA and Takayasu, but at the current time, again, in clinical practice, there is no current role for B-cell depleting therapies in the treatment of patients at this time. So how do we think about biologic therapies as we do apply these to patients with GCA and Takayasu's arteritis that we may be seeing in clinic? I think in the newly diagnosed patient, the data does not support that there is any biologic agent for which there is sufficient evidence of efficacy to support its use in this setting, of course, in combination with glucocorticoids. The question often comes, though, in those patients who have relapsing or potentially resistant GCA or Takayasu. And the issues that we have to weigh when considering a biologic agent in these settings, again, reflecting on what is the available data that we have with the biologic agent that we are considering. What are the goals that we are hoping to achieve by adding a biologic agent? Again, this may be different as far as if we have a patient who is clinically stable on 5 milligrams of prednisone versus someone who, say, cannot get below 15. How are we going to assess whether we are meeting those goals because of the challenges we recognize in adequately assessing disease activity in large vessel vasculitis? Of course, the safety profile of the agent that we are considering, and then individual patient factors that could increase toxicity for that specific individual. So in shifting then to other vasculitic diseases, in cryoglobulinemic vasculitis, we recognize that this is a disease in which we can see cutaneous, musculoskeletal, nerve, and renal involvement. And over 80% of instances of cryoglobulinemic vasculitis are related to hepatitis C. When we think about the potential pathogenic mechanisms that may occur from viral replication leading to antibody formation and then stimulation of a clonal or oligoclonal B cell expansion, we see that there are strategies that we may have for treatment in terms of interfering with viral replication, removal of the cryoglobulin precipitate through plasmapheresis, interfering with what is taking place within the vessel wall through the use of conventional immunosuppressives, or inhibiting B cell expansion through the use of anti-B cell based therapies with rituximab. Rituximab was explored in 2 randomized trials published in Arthritis and Rheumatology in 2012. Although there were differences in design, both of these, interestingly, were halted by their safety boards for evidence of efficacy that was disproportionate between arms, supporting rituximab as being far more effective. Remission was achieved in both of these studies and supported efficacy for the use of rituximab in this setting. Now, when we again look at these strategies, even beyond B-cell depletion, we know that, again, immunosuppressives, there's actually a relatively low amount of data with this, where this may increase viremia. Plasmapheresis, again, can be an acute option, but is not very good for long-term in terms of the risk of thrombosis and infection. And again, I think what highlights this as far as where our future lies is in antiviral therapies. This remains the first choice of treatment for hepatitis C, and with the evolution that we are rapidly seeing in newer agents for the treatment of hepatitis C, this is a form of vasculitis for which there is much encouraging news that lies in the future. With Behçet's disease, this is a complex form of vasculitis in which we can see a diversity of manifestations ranging from oral and genital ulcers, which can have significant impact on quality of life, to potentially life-threatening manifestations with thromboses, aneurysms, CNS, and GI disease. Ocular disease can occur in anywhere from 25 to 75% of these patients. Where it is more common in men, it is frequently bilateral and can be associated with blindness. This is most commonly a panuveitis, but occurs as an anterior uveitis in 20%. The treatment of ocular disease has expanded well beyond systemic glucocorticoids and conventional immunosuppressives. And the use of anti-TNFs have been studied in a number of different studies where these have demonstrated benefits. There has recently, in 2014, been support by an expert panel for the use of monoclonal antibody-based therapies with infliximab and adalimumab as a first-line therapy for ocular manifestation of Behçet's, making this a valuable addition to our treatment approaches. Now, in the spirit of presenting you with the most recent data, and this actually comes from a publication from the New England Journal that just came out within the last 2 weeks, apremilast has been explored as an agent for Behçet's as well. The oral phosphodiesterase 4 inhibitor was explored in this blinded trial in which patients were initially treated with either apremilast 30 milligrams BID or placebo. And then at week 12, again, continuation of the blind, those who received placebo also were treated with apremilast until week 24. And then both arms were stopped with an observation period for an additional 4 weeks. This study involved 111 patients with Behçet's, most of which were enrolled in Turkey, although there were a few in the United States. And these patients needed to have 2 or more oral ulcers. The primary endpoint of this trial was the number of oral ulcers at week 12. And at that primary endpoint, the number was statistically lower in those who received apremilast as compared to those who received placebo. Other important secondary outcomes included that there was a lower rate of pain in those who were treated with apremilast, and those who had no oral ulcers or who had a complete response was 71% in the apremilast arm as compared to 29% of those who received placebo. In terms of side effects, there was a higher rate of nausea, vomiting, and diarrhea in those treated with apremilast. But these results did provide some evidence of support that apremilast was effective in treating oral ulcers and Behçet's disease. The questions that still remain as far as whether the size and duration of this study were really insufficient to assess the long-term efficacy, and also what we would be very interested in terms of the effect on other Behçet's manifestations, which is unknown at this time. Now, finally, eosinophilic granulomatosis with polyangiitis, or Churg-Strauss syndrome, is a disease for which we have been interested in therapies for a long time. This is a disease characterized by asthmatic and allergic features, peripheral and tissue eosinophilia, as well as vasculitis, which can be life-threatening. Treatment currently is based upon disease severity, but asthma can be particularly difficult to treat and can limit glucocorticoid tapering in a number of instances. There was recently a study published in 2014 exploring the use of Rituximab, and certainly the question has been, as far as this was effective in other small vessel vasculitides with GPA and MPA, is this of benefit in EGPA as well? This was a retrospective report from combined 4 centers in which patients had been treated between 2003 and 2013. This was a combination of patients who had been refractory, relapsing, or a small number of new diagnoses, and included both single course as well as repeat dose schedules. By 6 months, 83% had improved, with 34% achieving remission, which rose to 40% remission rate by 12 months. Although glucocorticoid dosing was able to be decreased in all patients, by 6 to 12 months, only 6% were able to come off completely. And it is difficult to ascertain the response of the asthma component in this series. 15 infections were observed during this experience, with 6 being severe. So, although this study, again, was encouraging in terms of potential role for Rituximab, its overall role remains unclear based upon the retrospective experience, and this is, again, being explored in larger scales. Now, an agent we have had great interest in has been mepolizumab, or anti-IL-5. In EGPA, the eosinophil has been a cell and mechanism of great interest, and IL-5, a cytokine which has a central role in the proliferation and activation of eosinophils. Mepolizumab has been studied with promising results in asthma, published in the New England Journal last year, as well as the hypereosinophilic syndrome. There have been 2 pilot studies conducted in EGPA in 2010 and 2011. In one study of 10 patients, where patients received 9 doses of mepolizumab once a month and then were switched to methotrexate, the eosinophilia rapidly went to 0. And on those treated with mepolizumab, 8 achieved remission, with 6 then relapsing upon the transition to methotrexate, suggesting encouragement towards benefit. This has prompted the conduct of a randomized trial, which is currently being conducted in GPA, and we look towards this, again, with great interest. So in conclusion, with the use of biologic agents in vasculitis, the experience with rituximab in GPA and MPA has been important in showing us that biologic agents can have the potential for efficacy in vasculitis. However, randomized trials have shown that being a biologic agent in and of itself does not assure efficacy, even with the strongest rationale. Outside of a randomized trial, use and practice of a biologic agent must be viewed with caution, weighing the effectiveness of our current standards, considering the body of evidence supporting its safety and efficacy, and assessing the goals that we wish to achieve by using a biologic agent in our patients. So biologic agents have been beneficial in certain vasculitides. Again, use in clinical practice must be weighed based on data and goals. And the investigation of biologic therapies in vasculitis, some of which I hope to share with you today, is ongoing and is essential. Thank you very much.